Options to maximize bone health. Is the osteoporotic spine just an aging process or is it a pathology? These photographs I borrowed from Dr. Abhay Nene, and I'm sure he loves these photographs. Someday we'll have photographs of him here. Well, in the osteoporotic spine, is it decompression alone or decompression with instrumented stabilization? We've been discussing it for quite some time. My guess is as good as yours. Decompression could be in any form and is safe if done properly. You could do a fenestration, a laminotomy, an interlaminar discectomy, or a laminectomy. There's no way, if you are cautious enough to keep the stabilizing sort of segments intact, that you'll end up with a post-operative issue. However, there are certain situations where you need to look at instrumented fusion. If so, what do we do? I take you about 2.5 decades back. We used to put these large mesh cages and put in implants, and we never did a DEXA or a QCT. Never thought of it. And what did we end up? Well, we put these cages in there, and sooner or later, they would sink subsidence, late or even early, as in this particular patient, postmenopausal. At times, we were very, very aggressive, and we hammered them in. They stayed there, but they caused an early adjacent segment disease, or as in a smoker, they tilted. All these were late sequelae of surgeries I did 2 to 2.5 decades back. Then I moved to trying and using the hybrid. What was the hybrid? Well, I would stabilize one level and sort of diffuse the adjacent segment by putting in a flexible rod at the next level. What did I do then? Well, if I had to address this particular patient at 3 levels, I would fuse the lowest, give a sort of decompression with a mobile segment, but prevent non-physiological loading at the next, and do a micro decompression at the third. Well, they did stand the test of time for some time. Then came the non-fusion options, and we did try a few of them. All these in the osteoporotic spine, nothing really stood the test of time, whether pedicular or interspinous. Came back to using the miracle principle, which is minimal invasiveness, risk and cost, which can have a lasting effect by treating the man or woman and not the scan. This probably is what I have understood over the last 2 decades. If you have an elective spine surgery, we're not talking of emergency. Emergency, everything is course correction, it's emergency. But if you have elective spine surgery, which you can defer, well, if the T-score is less than 2.5 at the lowest in the skeleton, spine, hip, or forearm, if you have a diabetic or a smoker with a T-score less than -2, that means you give them actually an additional 0.5, or you have a patient on steroids, you will have glucocorticoid-induced osteoporosis, thyroid medication, seizure medication, patient with Parkinsonism, very, very, very bad risk. डिफॉल्टर विद एंटी ऑस्टियोपोरोटिक. सर हमने 2 महीने के लिए टेरिपेराटाइट दिया, फिर डॉक्टर साहब ने बोला बंद कर दो. क्यों दिया? वो हमको हड्डी में थोड़ा सा मार लगा था. नो सर, बी वेरी वेरी केयरफुल. दे आर एज बैड एज डिफॉल्टर्स ऑफ एंटी टीबी मेडिकेशन. Absence of red flags. That means there is no cauda equina. You don't have to. If you saw me, I was insisting on waiting in Gautam's case. Why was I waiting? There were no red flags. No recent worsening. If you're the same, you can still hold on under treatment. In these patients, what do? Counsel. Counsel, counsel. Reassure, brace them. Howsoever fat you can get a brace made, my dear friend, try it. Critical observation, follow up, video consult with these patients. Use it, aggressive anti-osteoporotic. I've used everything. I've used teriparatide, the original product. I've used denosumab, combined the two. I've even used high-dose miacalcic nasal spray as pain relief. It does buy time. If not 200 IU, use 400 IU per day in these obese patients. It works. Please try it. Give it for 6 weeks. Works. Then, of course, teriparatide 20 micrograms, denosumab 60 milligrams, calcium, vitamin D supplements, fall prevention at home, and review for surgery at 3 to 6 months. There is no evidence in my hands, but I've seen patients and I've at least counseled and deferred, denied, delayed surgery for 3 to 6 months with teriparatide, gone in with T-scores which were minus 3.5 earlier, have put in normal screws thereafter. So they do work if you can defer or deny them for at least 6 months. What are the bailout outcomes still? You can use uninstrumented fusions, you can use BMP, you can use customized bracing. You can have cement augmented screws, fenestrated screws, hydroxyapatite coated screws. Do multi-segment, go long if you feel that short is not working. No harm, it doesn't affect your ego. It's an elderly patient. Use dual modalities, use screws, use wires. We've used both of them and we've combined the two. Stainless steel ring and wires work. MRI किसका होता है और अगर होता भी है तो with Mars protocol you can get away and see what you want. Don't just throw that heart shield or that stainless steel loop out. It's a very, very effective component of our treatment as far as medication as well as surgical treatment in the elderly. Finally, what lessons have I learned? If the patient has more symptoms than signs, let the patient buy the option, especially in the elderly. Yes, if there are more signs, cauda equina, urinary insufficiency, women hide their urinary dysfunction. Ask them leading questions, take them aside, please counsel them. Then they need surgery. Elderly osteoporotics start aggressive medical treatment. Complex LCS, a lot of these patients we see them, scolies, listhesis, redo surgeries. Always remember less is more. Find that particular point, targeted surgery. Don't do the whole hog and collect all those deformities. Whenever your instrument you have to use it. If you have to use BMP, use it. Screws, wires, combine them. Use whatever technology and technique you have. Use AI if you're naturally stupid like me, use AI. Use the RoboNav. Use minimally invasive surgery. Have a good ICU backup. Don't do these in setups where you don't have an ICU backup. They are elderly patients. Whatever you may do may bounce back at you if you don't look after them post-op. Today, I don't know what the future is. We're talking of fusions. Tomorrow, there may be a non-fusion option. We've moved from open to minimally invasive. We may go back from instrumented to non-instrumented. Maybe surgeons will be out. It may be gene therapy versus biologics versus metal. Finally, whenever you do the surgery and we keep talking about the product we are going to do or the process that is going to be done, why are we doing it? You may execute a surgery like that. I don't know why it was. If you don't know the purpose, this is what. If you inadequately execute. I've spent a long time trying to correct my own mistakes. It's the Dunning Kruger. The more you know, the less confident you're likely to be. Because experts know just how much they don't know. They tend to underestimate their ability. They're vulnerable. But it's easy to be overconfident when you only have a simple idea of how. Try not to mistake the cautiousness, the lack of understanding. Not to give much credence to lay people who appear confident but have only. I quote Bertrand Russell. The whole problem with the world is that fools and fanatics are so certain of wiser people, so full of this. Gentlemen and ladies, behind every successful, a lot of uncertainty. And as I said, results come. Thank you very much.